Hello, everyone. My name is Beydoun, and I am a staff scientist at the Laboratory of Epidemiology and Population Sciences at the National Institute on Aging, NIA-NIH-IRP. Just a little bit of background. I have a doctoral degree in epidemiology from University of North Carolina at Chapel Hill. And then I went on to do a postdoctoral training at Johns Hopkins School of Public Health. I am interested in nutritional epidemiology, health disparities research, and cognitive aging. Dr. Canas.
Yes, good morning, everybody. My name is Jose Atilio Canas, and I am a pediatric endocrinologist with the Division of Diabetes at the Johns Hopkins Old Children's Hospital in St. Petersburg, Florida. I graduated in 1983 from the Universidad Nacional Pedro Enrique Sureña, and I am interested in fat accrual and the use of supplements from plant-based to reduce the accrual of obesity in children.
Thank you very much. Today we will be discussing a new paper that was published in Neurology, which is entitled Association of Non-Alcoholic Fatty Liver Disease and Fibrosis with Incident Dementia and Cognition, the Rotterdam Study. A non-alcoholic fatty liver disease is an umbrella term for a range of liver conditions affecting people who drink little to no alcohol. As the name implies, the main characteristic of NAFLD is too much fat stored in liver cells. NAFLD is increasingly common around the world, especially in Western countries. Globally, 1 in 4 adults has non-alcoholic fatty liver disease, and in the United States, it is the most common form of chronic liver disease. Some individuals with NAFLD can develop non-alcoholic steatohepatitis, an aggressive form of fatty liver disease, which is marked by liver inflammation and may progress to advanced scarring or cirrhosis and liver failure. This damage is similar to the damage caused by heavy alcohol use. So we know from previous studies that NAFLD screening can prevent cardiovascular disease, extrahepatic and hepatic malignancies. It's important to note that dementia is another common condition among adults aged 60 years or older, and it's a primary cause of disability in developed countries and of healthcare burden in old age in general. Globally, its prevalence has been estimated at about 4.7%, with the majority being caused by Alzheimer's disease, so about 60 to 80%. And Alzheimer's disease, as you know, is characterized by a pathological buildup of brain proteins, including A-beta amyloid and neurofibrillary tangles. Now, Alzheimer's disease could be early onset or late onset. Early onset has a very strong genetic basis, whereas late onset Alzheimer's disease has a small fraction of its incidence related to genetics. And factors such as education, smoking, physical inactivity, depression, midlife obesity, hypertension, and type 2 diabetes may explain about half of late onset Alzheimer's disease variation. Now, based on an estimation of the population attributable risk for dementia in general, which includes vascular dementia, published recently in the Lancet Commissions, around 1% of dementia risk can be attributed to obesity at midlife, but 60% of the attribution to the risk of dementia is largely unknown. Before next, Dr. Canas will talk to you a little bit more about the biological mechanisms and other important issues, but it's important to note that obesity is also a very important risk factor for NAFLD and fibrosis.
Absolutely. So, as you know, given the fact that there is no cure for either dementia or non-alcoholic fatty liver disease, preventive efforts are key to alleviating their burdens, particularly as midlife obesity and related cardiometabolic risk factors contribute to both conditions and are particularly responsive to lifestyle changes. So that's the key message. Furthermore, there is speculation that non-alcoholic fatty liver disease may trigger age-related cognitive decline by directly promoting brain structural changes via the liver-brain axis, which involves several mechanisms, including inflammatory mechanisms such as liver fat or complex glycolipids accumulating that can activate microglia and in turn increase cytokine expression and amyloid beta or tau protein production in the brain. But there's also speculation that non-inflammatory mechanisms such as insulin resistance, hyperglycemia from type 2 diabetes, oxidative stress, dysbiosis, and hemodynamic or prothrombotic events that are typical of cirrhosis may eventually lead to activation of the Alzheimer's pathways.
Thank you, Dr. Canas. So we both read with great interest this article, which is published by Chow et al. In Neurology, that describes the association of non-alcoholic fatty liver disease with incident dementia and cognition. Now, using data from the Rotterdam study, and this is an ongoing prospective core study, NAFLD was defined as fatty liver index, or FLI, greater or equal to 60, or steatosis on abdominal ultrasound, or AU, and also as fibrosis, fibrosis as liver stiffness measure, or LSM, with 8 kPa or more. Cognition was evaluated using a large battery of tests covering several domains, including memory, psychomotor, speed, and attention, while incident dementia was diagnosed using DSM-3 criteria. Now, data from 3 sets of patients, as you can see in here in figure 1, was considered. Patients in set 1 were enrolled in 1997 to 2002. As a result, their length of follow-up, the median length of follow-up was longer than the remaining 2 sets. The sample size was 3,975, mean age is 70, and the follow-up period is 15 years up to around 2018, I believe. And this set had FLI measurements, fatty liver index. Patients in sets 2 and 3 were enrolled in 2009 to 2014. Set 2 consisted of 4,577. Mean age is similar to set 1, so about 70 years, but the follow-up period was only, median was 5.7 years. This set had abdominal ultrasound data available. And finally, set 3 had LSM data available, so fibrosis, and the sample size was 3,300. They were slightly younger than the other 2 sets, so the mean age was 67.6, and the follow-up was 5.6 years. So the authors actually ran several Cox proportional hazards models to answer their main questions. And as you can see here in tables 2 and 3, you can see there's different definitions of NAFLD and fibrosis in relation to dementia. And model 1, they adjusted only for sociodemographic factors and ApoE epsilon 4. And model 2, they added some lifestyle and health-related factors except BMI, whereas in model 3, they also added BMI. So model 3 is considered the fully adjusted model. So what they found is that NAFLD and fibrosis were not associated with increased risk of dementia. The hazard ratio for NAFLD based on FLI was 0.92. With a confidence interval of 0.69 to 1.22, and for fibrosis, it was 1.07 with a confidence interval of 0.58 and 1.99. So both confidence intervals include the value of 1, so that's why it's not significant. And they did not detect any relationship between NAFLD and impaired cognitive function in general. Unexpectedly, NAFLD was potentially protective within 5 years of follow-up. So this is looking at table 3. This is patient set 1 who had data on fatty liver index. So they basically stratified their analysis based on length of follow-up. And what they found that if the follow-up was less than 5 years, the hazard ratio was 0.48 and the confidence interval is 0.24 to 0.94. That suggests that suggesting NAFLD's regression driven by weight loss before dementia. And we know that right before dementia, there's evidence that weight loss often occurs. So this finding does not necessarily mean that NAFLD is protective against dementia, but that it is related to weight loss, which then is inversely related to NAFLD.
So to summarize, I think these findings replicate previous published studies indicating that simple steatosis is probably not an independent risk factor for cognitive dysfunction. However, liver fibrosis, on the other hand, may, or it appears that it may be a determinant factor for disease progression. And indeed, people with higher degrees of liver fibrosis are more prone to poor long-term outcomes, including overall mortality, especially in the frail and aging population. So in the present study, I think the authors report that in those individuals with a liver stiffness measure of 8.0 kPa, measured by transient elastography, there was a significant association with impaired cognitive performance on the Stroop test and the letter digit substitution. So this is in the figure 2, where they have the cross-sectional results with the cognitive test. These tests cover attention and concentration processing speeds and global cognitive function respectively. So there's a hint that something is going on with the increased risk for liver fibrosis onto cirrhosis, which would be a score of somewhere around 13 kPa. So this has been replicated in previous studies, including a similar study published by Weinstein et al. In 2019 in Liver International, where they studied 1,287 participants from the Framingham Heart Study, age 61 plus or minus 12 years, and 48% of them being men. And they found that NAFLD in 378 participants, or a prevalence of 29%, had no association with impaired cognitive function. However, when they looked at those high risk versus low risk fibrosis scores, they did find that there was poorer performance in the cognitive test in those with the higher advanced fibrosis scores. And they have followed up those numbers now in 2022 with a recent report this January in the Journal of Alzheimer's Disease, which includes now 5,841 Framingham Heart Study participants from 2 waves, the offspring and the 3rd generation cohorts. These were exams 9 in the year 2011 to 14, and the exam 2 in the year 2008 to 2011, respectively. And they are now reporting that the prevalence of NAFLD has increased to 34%. And that, again, it was not associated with the proteins that we associate with Alzheimer's, such as amyloid beta or the tau protein. And they looked at this by tau PETs, which are very, very specific type of PET scans looking for damage or imaging that would be respective of Alzheimer's. So in a subset of those individuals with NAFLD, now 177 individuals that had fibrosis parameters measured, their mean age was a little younger, 50 plus or minus 10, 51% males. And the prevalence of advanced fibrosis was 19%. So only 34 of those individuals had advanced fibrosis scores with an index that they describe as 5-4. So the 5-4 index was significantly associated with increased renal tau by PET, and their beta is 1.03 and their P score is 0.002. And they also found that amyloid beta deposition overall is specific to the inferior temporal and parahippocampal regions of the brain. Therefore, these are more specific areas of the brain being looked at, and yet these individuals do not have cognitive dysfunction quite yet. So this is very, very tantalizing evidence that there is some association between advanced fibrosis and Alzheimer's progression. So when you think about what we are seeing resulted in this Rotterdam study, they are using the score of 8 by transient elastography to characterize the potentially histological proven advanced stage of fibrosis. However, when we reviewed the literature, we believe that there's a need for a higher LSM score in order for you to really detect the advancement of the liver fibrosis, which is leading now into probably some type of inflammatory change. So as you know, liver fibrosis is a normal process that is completely reversible. However, once there's inflammation and hepatocyte death and the cellular death, then you begin to have more of an advanced stage. So I think we're probably going to say that this is very tantalizing evidence, and we need further studies from that.
Oh, thank you, Dr. Canas. That's very interesting take on that. We're moving on to the strengths and limitations of the study. So the study by Chow et al. Lists several strengths, and I thought that the main strength is that they are using the Rotterdam study, which is very well established prospective cohort study, in a very efficient way by using all types of measurements that are available to define NAFLD and fibrosis. Also, the main findings of a protective effect is both a strength and a limitation. It should be interpreted with caution. And then there are several limitations that were listed by the authors. The first one is that the cohort is entirely European and the findings may not be generalizable to other populations. And then they also identified lack of liver biopsy for assessment of NAFLD fibrosis and the use of lower LSM score to characterize it. They also list residual confounding, which is very common in observational studies. They try to account for most of the potential confounders, but it's possible that they have missed or they mismeasured some of them. There's lack of information on exposure duration. So they don't know for how long they had NAFLD or fibrosis. And a small number of patients had unquantified fibrosis. Also, there's cross-sectional analysis as shown in figure 2 here. The cognitive tests are based on cognitive test analysis is based on cross-sectional one-time point outcome. And ideally, you would like to look at NAFLD and liver fibrosis in relation to cognitive decline, the way they looked at incident dementia. And then finally, the survivor bias is a main limitation.
Yeah, and these are key points, I think, for the interpretation of the study. Certainly, longitudinal is much more helpful for us. So hopefully in the near future, with advanced diagnostic approaches to quantify early versus late hepatic fibrosis using either proteomic analysis derived markers or serial serum samples in conjunction with MRI elastography, which appears to be a better predictor than ultrasound elastography, may obviate the need to utilize liver fibrosis as the golden rule to assess pathological stages in liver fibrosis.
So it can be concluded from this that future studies are needed that should focus on NAFLD duration and fibrosis trajectory in relation to cognitive decline and dementia risk. So Dr. Canas, do you have any other comments on the study?
No, I think it's a great study. Sometimes we think that negative studies may not give us an inkling into what we really need to focus on, but this study certainly, it's tantalizing to think that choosing the right parameters to follow individuals that are leading to late stage fibrosis is as important as knowing whether they have NAFLD or not. So I think it's a great study.
Yeah, I agree. And I think they use the data very well in Rotterdam study. I would have liked to look to have more stratified analysis, especially that they have men and women. Many of my studies are actually stratified by sex and by race, but in this case, they're all Europeans. They could have found some interesting results that are different between men and women, but maybe they didn't have enough statistical power to do that for all of the patient sets, I guess. And also, even though they have combined cognitive tests and a global cognitive function score, they could have also combined the domains together, like memory, attention, concentration. Those could have been in one combined. There's more data reduction that could have been done as well, to have just a general idea about what's going on.
Thank you.
Thank you, Dr. Canas, and thank you. We would like to thank Neurology for inviting us to give this, to do this discussion. Thank you.